So in terms of hemorrhagic disorders, I started with this, even though it represents the minority of stroke. It's about 15% of stroke. But nonetheless, this is the more grave of the, loosely, bin types of stroke disorders, whether ischemic or hemorrhagic. And so I'll be talking about aneurysms, AVMs, and arteriovenous fistulas. I'm going to just showcase some cases to kind of illustrate what we're doing in a lot of these instances. But I'm also going to try to provide some of the evidence that actually substantiates our role in the treatment of these diseases as well. So I think a lot of us understand what a brain aneurysm is. It's a relatively prevalent disease. So about 1 in 100 to up to even 1 in 20 of the patient populations that we encounter will have an aneurysm. A minority of these aneurysms will rupture annually, about 1%. But nonetheless, when the aneurysms rupture, they carry severe morbidity and mortality, and that's why we put such a premium on trying to identify them and treat them before they rupture. They typically affect older populations, people in their 50s and 60s, and there is a female predilection in terms of gender. In terms of the natural history, it's complex. It's not something that's as simple as, 1% a year or 0.5%. It's going to vary based off of risk factors, some of which are modifiable, such as smoking or hypertension, some of which are mutable, such as gender or having other genetic disorders. But suffice it to say, in addition to all of the epidemiologic elements and then the comorbidities, there are also information about location of aneurysms, size of aneurysms that we all integrate into a risk stratification to try to educate patients about management decision-making. Aneurysms are a heterogeneous disorder. Obviously, most of them are saccular in terms of their morphology, but some of them can be fusiform or dissecting. And obviously, most aneurysms are small when they're originally detected. And obviously, as aneurysms get bigger, their risk of rupture increases. Most aneurysms are in the anterior circulation. Again, that's just part of the physiologic reality that most of your blood supply goes to your anterior circulation. But nonetheless, posterior circulatory aneurysms are important because they also carry what we think is to be a higher risk of bleeding annually than an anterior circulation aneurysm. So this is a cartoon, just kind of walking through some of the pathophysiological changes that can happen in a vessel that can lead to the formation of an aneurysm and then its rupture. But essentially, it's an interplay of mechanical forces or hemodynamic stresses on the vessel itself in combination with the genetic elements that are actually present in those cells. And so in that process, that feedback loop of disorganized or abnormal types of physical interactions mixed with the biochemical changes that happen within cells, the degradation of the wall can persist and ultimately can lead to vessel rupture. Ultimately, despite having this information, this nice cartoon, we still don't actually know who will always form aneurysms, where those aneurysms will form, and most importantly, we don't know with a high degree of certainty which aneurysms will ultimately rupture. So this is an area of active research for all of the community. So this is an angiogram. So you're looking at as an anterior-posterior projection of the right internal carotid artery. You can see here there's some extra material, and that's the posterior communicating artery aneurysm, which you can see in relief much better in the lateral projection. So here's the posterior cerebral artery here. This is the internal carotid artery here. This is the anterior cerebral artery here, and the middle cerebral artery is here. And so this patient came in with a ruptured aneurysm. You can see it has a somewhat abnormal morphology. It has a little daughter here, and this is a 3D rotational rendering of that same image. So what do we do with a patient like this? This is before. This is what we place our coils. These are fine little filaments of platinum metal that we can put directly into the sac of an aneurysm to prevent it from filling with blood and obviously prevent it from rupturing. And this is what it looks like after we treat it. So this very loosely is the Raymond classification, and this is, I'm going to show you some of the evidence as to why this classification is important in just a second, but this is what we consider a complete occlusion, meaning there is no blood flow getting to the aneurysm, or Raymond 1. This is what we call a residual neck, or Raymond 2, and this is what we call residual aneurysm, or anything that isn't within basically categories 1 and 2. So a residual neck essentially has the same natural history as an aneurysm that's been completely occluded. And so we consider these sufficiently treated, whereas this type of aneurysm we think may require additional treatment. And this is based off of what is the only real randomized trial in this space, the International Subarachnoid Aneurysm Trial, the ISAT Trial, which was published in Lancet in 2002, which was a randomized trial looking at Coiling versus clipping of ruptured aneurysms, both in European and North American centers. This was a trial based on the equipoise of certain aneurysms. So again, these were all anterior circulatory, and they did not include middle cerebral aneurysms. And so though this data has been extrapolated to kind of the general aneurysm population, as well as the unruptured aneurysm population, its scope was certain aneurysms in the anterior circulation, again, and only in the ruptured setting. So again, it's a 1-to-1 randomization. But at 1 year, patients that underwent coiling versus those that underwent clipping had a significantly lower rate of being dead or disabled. And as such, they stopped the trial early because of the disability-free survival that we just talked about. So not surprisingly, this has come under considerable criticism from, especially from the surgical community, who felt that the fact that the trial didn't have any long-term follow-up really was a disservice to microsurgical clipping. And ultimately, the rebleed rate was higher, though very low again in the coiling group versus the clipping group. It was still higher. And again, we'll talk about that in just a second as to how that impacts long-term follow-up. But to get back to the previous slide showing that the levels of occlusion, essentially what they found primarily from this group is that, or from this study, was that if you did have an insufficient or what we call like a Raymond type 3 coil embolization, your risk of rebleeding was significantly higher versus those that did not. And so this is again the impetus or the rationale for why we treat aneurysms, even those that are partially treated in the past, we treat them again, obviously in subsequent follow-up. I should note that about 1 in 5 aneurysms will have some element of recurrence, and about 1 in 10 to about 1 in 15 will require some additional treatment. That's gotten better over time due to technological changes in device technology, as well as some of the imaging equipment, but it's still the recurrence rate and the retreatment rates are considerably higher than the microsurgical population. So in 2015, Annie Molyneux published the follow-up, the 10-year follow-up from ISAT. Obviously, the study had been completed 18 years, but again, it took this long to get sufficient data to do what was a prescribed 10-year follow-up. This is all part of the trial. And you can see how many patients were alive within the UK database, and obviously needed a minimum of 10 years to follow. And so what you see here, this is the rebleeding rates. So this is the Kaplan-Meier curve here on the bottom. And what you can see is indeed there's a statistically higher rate of rebleeding in the endovascular arm here in blue relative to the neurosurgical arm. But you can see here the absolute number of these is still relatively very small. Though it carries statistical significance, again, it should be noted that the ISAT trial represents technology that is now almost 25 years old, and our ability to get better results in an endovascular fashion have improved over that interval as well. But ultimately, the real purpose of the study was to determine about functionality and mortality. And the point here is that at the 10-year mark, and granted we have some patient data out to 18 years, again, the numbers are smaller. At the 10-year mark, you can still see the delta here relative in the endovascular versus neurosurgical arm. And what you're looking at here is the cumulative mortality rate. And so again, patients were less likely to be dead or disabled at 10 years follow-up. And so the effect that we do see in terms of the injury or the comorbidities related to microsurgical clipping can still persist out to that level. So in that regard, there's still very good evidence to suggest that endovascular treatment is probably not the gold standard, but certainly a very, very attractive option for patients with subarachnoid bleeding. In fact, most patients are now treated worldwide through endovascular means for aneurysms, whether it be in the emergent setting or in the elective setting. So let's move on to arteriovenous malformations. This is now going to drop in prevalence relatively precipitously. So these are abnormal connections between arteries and veins with a series of malformed vessels in betwixt those two channels. And they do have a propensity to hemorrhage. So about half of patients with AVMs will present with a hemorrhage. You can see that it has a relatively equal gender predilection. And again, AVMs can be even more impactful sometimes than aneurysms because they affect people typically right in the middle of their life in their 40s. And it's really kind of equally distributed down into then older patients, but also into the pediatric population. As it relates to natural history, again, we have fewer patients to study than aneurysms, but The ICH rate, or the hemorrhagic rate, ranges anywhere to about 1% up to 4%, just depending on how the patient originally presented. Obviously, patients that present with an ICH have a much higher rate of rebleeding within the first calendar year. There is good randomized data. The Aruba trial is the only randomized study that we have looking at observational management versus any type of surgical management, whether it's microsurgical, endovascular, or radiosurgical. And this trial was assailed again by a lot of the surgical community because of the heterogeneous treatment recommendations or protocolization that happened there. And again, what came out of that trial, as with ISAT, is that early on, at about the 36-month mark, the trial was stopped because observational therapy carried significant less burden and mortality than any type of surgical management. And so that study, unfortunately, does not have a continuation in terms of its long-term outcome yet. We'll see as the time goes on to see how those patients do. But ultimately, AVMs are still much more controversial in terms of how they're managed. I should note that the microsurgical community has published multiple papers looking at what they call Aruba-eligible patients and tried to compare them in a case-control fashion, their surgical series relative to the observational data sets from Aruba, and shown that microsurgical intervention can be very effective in certain types of AVMs in the unruptured setting. So in terms of imaging for these patients, is again, because hemorrhage is a common presentation, CT is really the workhorse. Obviously, you can see calcifications in the non-ruptured setting, which can help you make the diagnosis. MR, though, is essential in terms of working up with these patients. The susceptibility sequences, such as GRE and SWI, can help us detect microhemorrhage, which is essential in terms of trying to understand, even in patients who have a benign clinical presentation, that these microhemorrhages could prognosticate a higher rate of bleeding than a patient who did not have them. Arterial spin labeling and functional imaging are also important in terms of trying to find subtle shunts or trying to compartmentalize arteriovenous components within the AVM, as well as the surrounding, or the functionality of the surrounding brain parenchyma. Angiography, whether through MR or CTA, is really helpful in getting a collective understanding of the entirety of the AVM. But again, this is a neurointerventional talk. DSA, or digital subtraction angiography, or catheter angiography, really remains the gold standard, and any patient who's undergoing a workup or any sort of like definitive follow-up of an AVM certainly needs to have an angiogram to make the management planning decisions, especially as it surrounds any sort of endovascular treatment, but also microsurgical or radiosurgical therapies. So here are some just cases, just nicely showing some of those things we were talking about. Here's a CT, just showing these calcifications surrounding this large varix, which you can see better here on MR, on a T2-weighted MR, and then all these vessels in and around the AVM. Here is the corresponding angiogram. This is an internal carotid injection. You can see this large afferent feeding into a varix. Here it is in AP projection. But what you can also see here is this is the posterior circulation of that same patient. You can see all these tiny little vessels here. These aren't actually pathological. These are POPL collaterals that the brain is essentially increased in volume because of the shunt flow here. The brain that surrounds this has been starved of oxygen because these normal vessels are not supplying it. And so it's now picked up blood supply from other locations. And so these are important things to angiography can help delineate that you can't always assess on cross-sectional imaging. This is a patient with a hemorrhagic presentation here in the basoganglion insula. And you can see here's the lateral projection of the angiogram, just showing the AVM here located in portions of the frontal lobe. But you can also see it's important to look at the external supply. This patient actually had a small amount from the middle meningeal artery. And so again, blood supply to AVMs can be picked up in multiple locations. Here's another hemorrhagic presentation. This case I'm trying to show here, and for the purposes of showing what we call a split nidus, meaning that the hemorrhage itself can obliterate portions of the nidus. And so what you can see here on CT imaging is a portion of the nidus here, but also a portion more superficially. And that corresponds to that angiogram, which shows this deep component fed by enlarged lenticular striates off the middle cerebral artery. And then here it is in lateral projection. And here's it in kind of an oblique projection. But again, the anatomy can be very complex, particularly in the setting of hemorrhage. So again, angiography is essential in trying to make the determinations around management. Here's another case, T2-weighted MR. This is kind of a posterior thalamic AVM. Here's an enlarged PCA branch. And again, just showing the value or even the limitations somewhat of MRA in terms of the ability to show the arterial and the venous phases. And here it is in angiography, just showing that same information. But it also shows a nice embryonic persistence here of what we call the limbic arch. So this is a direct communication between choroidal branches off of the posterior circulation and the pericallosal branch off of the anterior cerebral artery. Again, this is all just normal variation, but it just speaks to the potential age at which this AVM may have actually formed. I mentioned bold or functional imaging. So here's a patient who has an AVM on the eloquent side, so it's the left side, but it's involving the temporal lobe. And you can see here, these are mapping of language centers and association centers within the frontal and temporal lobes to try to better understand if resection or radiosurgery were to be performed, what kind of functional deficits this patient might experience. Here's another 3D rotational projection. This is a posterior circulatory AVM, and you can see here there's a flow-related aneurysm. Should be noted that this has been documented in a number of retrospective series that posterior circulatory AVMs will carry higher rates of flow-related aneurysms, and as such, will carry a higher rate potentially of subarachnoid bleeding. Other publications have noted that though hemorrhagic volumes can be smaller in the posterior circulation, the clinical presentation can be much worse. And as such, though we don't have a true natural history score for AVMs, all of the scales that you see really relate around treatment risk. Posterior circulatory AVMs, I think, should be carried with a little higher weight than, let's say, one in the superior or the supratentorial space because of these particular issues. But again, this is just showing an aneurysm, and you can see that same aneurysm in projections here on the angiogram. This also, brings to point the fact that when we do embolization, which we're going to talk about in just a second, targeted embolization or treatment of high-risk features can be really important in terms of modifying the natural history. So in patients who come in with, let's say, a subarachnoid hemorrhage in the setting of an AVM, oftentimes it's a flow-related aneurysm that's bled, or an intranidal aneurysm. And if you can, we have evidence to suggest that if you can embolize those particular high-risk features, you can shift or modify the natural history of that AVM back into what we consider a non-hemorrhagic type natural history. So as I mentioned, here's a case of why we use embolization. So here's a very high flow frontal AVM supplied by large branches of the middle cerebral artery. You can see it here in frontal and lateral projections. And so the purpose of embolization is ostensibly, in most cases, to do one of three things. One, to modify the microsurgical performance. So we try to reduce flow or take vessels that are very difficult to approach from an outside to inside manner to make that surgical resection safer and faster and more complete. Another, as I mentioned a second ago, is to take specific high-risk features to try to modify the ICH risk going forward. And last but certainly not least is the role of palliation in terms of embolization. So there are patients who have AVMs that are so unwieldy from a radiosurgical or microsurgical standpoint, yet they're symptomatic, whether it be from headaches or epilepsy or other types of issues, that we do try to essentially whittle down the amount of flow that the AVM sees in hopes that that can reduce some of the symptoms that patient might experience. So what you're seeing here is this is before and this is after. What you can see is that we've glued some of these large pedicles that feed the AVM. You can see here the truncation of these vessels on both the projections. And this is done with coils and MBCA or glue. And again, the whole purpose is to make that surgical resection safer and faster. Here's an instance where we're actually able to cure an AVM, though again, we're going to talk about that one in a second. But here's a choroidal AVM fed by a posterior choroidal branch on the left side. Here it is in frontal and lateral projection. And we actually treated this with ethanol. Absolute ethanols can be very effective in terms of sclerosing these lesions permanently. So in terms of the evidence for definitive treatment using endovascular means, certainly at UCSF we don't particularly try to cure AVMs in an endovascular fashion. When asked, or if we feel the anatomy is possible, we will try to do so. But in large part, as I mentioned, our role is adjuvant to other types of therapies. There is data, there are series in publication that describe attempting to definitively treat AVMs. More often, operators will use liquid embolics such as ethylene vinyl alcohol copolymer or Onyx, which is made by Medtronic, to essentially push into the nidus, casting the AVM, preventing it to have any more blood flow. The evidence on that is not great, and certainly it is not as effective as microsurgical techniques or radiosurgical techniques, and at least by the evidence and the literature, does carry a potentially higher rate of morbidity and mortality for comparable AVMs in terms of size and eloquence and location. So that brings us to dural fistulas. So now this is in the same family of vascular malformations, but this is different in that it's actually within the linings of the brain. And again, it's a subset of vascular malformations. So we're now talking about a very rare disease relative to aneurysms where we started. Now we start to see the female predilection again, and again, it starts to happen in older patients. In terms of a natural history, these, again, rarely spontaneously go on their own. Some of them can be post-traumatic. They do carry a variable rate of ICH, which we're going to expand on in just a second. But really that ICH is predicated on identifying what we call cortical venous drainage or leptomeningeal venous drainage, and I'll talk about the pathophys of that in just a sec. So in terms of imaging, again, as I mentioned, CT is the workhorse. It really helps us identify hemorrhage, which is really the big thing that we're trying to prevent. In terms of MR, time of flight angiography can be very helpful in terms of identifying early filling of venous sinuses or cortical veins. But oftentimes MRs can be misinterpreted because, again, dural fistulas are a rare disorder, so it's not making the differential for a lot of imagers, but it's something to always consider. But ultimately, if you want to understand a dural fistula, you have to do, again, a DSA. It provides the best spatial and temporal information and allows us to really dissect the different arterial components that feed into an AV fistula so that we can figure out what's the best way to treat it. So there are multiple different classification systems in terms of AV fistula. And I should say just really quickly, everything you're seeing here is based off of small retrospective series from centers of excellence, from operators of excellence. We at UCSF are one of these types of centers. As such, we feel like we have a good handle on this particular disease. But ultimately, none of this has the kind of level of evidence that I mentioned earlier in terms of having randomized or prospective studies to really understand this disorder on a much higher level. But ultimately, both the Cognard and the Borden classifications, what they're trying to get at is looking at the angioarchitecture of a dural fistula. If you're able to demonstrate any sort of cortical venous component, but particularly if that cortical venous component becomes more and more of the entirety of the venous egress from a dural fistula, the higher the rate of that patient's potential bleeding over time. And obviously, if there's evidence of changes in those veins themselves in the form of ectasia or varices, that's a real indication that those veins are overburdened by that high arterial flow and that you are going to have a higher risk of hemorrhage. So this is the Cognard classification, this is the Borden classification, which just simplifies that into 3 subtypes. So in terms of the low-risk patients, these are the patients who don't have a tremendous amount of high risk or a cortical venous drainage. They more often present with pulse synchronous tinnitus, headaches, or other types of regional pain syndromes. The high-risk patients, again, are going to more often present with hemorrhage or other types of end organ dysfunction, whether it's visual changes, seizures, infarcts, but you can also see personality changes as well. The venous hypertension that we see with this cortical venous drainage can cause parts of the brain in a very, very selective fashion to behave in ways that don't make sense. And so it can cause memory dysfunction and all kinds of other things. So it's important when you're looking at potentially an MR or a CT where you do see a lot of edema to not immediately rush to the ideas of infectious and inflammatory issues or tumor, but also consider vascular issues as well. So this is a good example of that. So this is a patient who has high T2 signal in the brainstem and the upper cervical cord. And this patient was ultimately thought to have a glioma or some sort of primary CNS tumor, and she ultimately underwent a biopsy of this area at an outside hospital. She came to UCSF for a second opinion, and our diagnostic colleagues who are world-class said, oh, you might consider that she might have a dural fistula. So indeed, we did an angiogram, and lo and behold, that's exactly what's going on. So here's a branch of the occipital artery, and that comes up and feeds what is a trapped or kind of essentially occluded sigmoid sinus. And so here you can see it actually on cross-sectional imaging. This is a CT that's derived from the angiogram. Again, I should point out the fact that in all modern angiographic system or angiosystems, we can actually do CT imaging. And so it just makes the whole system that much more powerful. But this is the recipient vein from which the venous drainage in and around the brainstem and the cerebellum is not flowing out. And so that pressurized those vessels, and you can see here these enlarged veins that are running down the spinal cord that are causing her symptoms. And so we were able to treat this in one setting. You can see here, this is the subtractive view, so there's no more shunt, and here's the unsubtractive view showing the onyx cast. And so, and this woman improved thereafter. But this woman was scheduled to potentially have a surgical resection of something or surgical exploration. And again, all she really needed to do was just have somebody, take some pictures of her vessels to identify what the problem was. So I'm going to pause here